RAÚL CHÁVEZ, and I'm going to present our poster named Bilateral Limb Neuropathy and Incapacitating Vertigo in a patient with a hidden lung neoplasia. Here we present a case of a man of 52-year-old who had smoked a long time and was admitted to our hospital. His symptoms initiated in July 2 years ago with bilateral lower extremities numbness and paresthesia with descending pattern. In December, these symptoms were also present in superior limbs. In January, he had incapacitating progressive, no-trigger, and continuous vertigo. He had involuntary weight loss of 20 kilograms. He received multiple drugs like gabapentin, duloxetine, vestibular suppressants, and antiemetics without improvement. In June, he went to our hospital emergency room. The HINTS test showed normal head impulse test, vertical nystagmus, and skew deviation. We concluded central vertigo. The rest of physical examination was normal. The labs also were normal too. Only the liver test had immunoglobulin G elevation with serum free light chain analysis, and serum immunofixation were also normal. The thorax radiography showed right iliac mass of 7.2 centimeters. A CT scan test with contrast documents a right iliac mass with focal necrosis zones that displaced the big vessels and bronchi. The antineuronal antibodies in serum were positive, and the cerebrospinal fluid were also negative. The brain MRI report hyperintensity in right basal ganglia and cerebellar cortex. The nerve conduction velocities pattern was axonal sensitivity neuropathy with motor axonal motor degeneration. So we integrated the diagnosis of nervous system paraneoplastic syndrome, specifically chronic sensitivity, motor axonal neuropathy, and cerebellar degeneration. The PET-CT showed an hypermetabolic mediastinal mass with cerebellar and basal ganglia metabolic enhancement. The thoracic surgery team performed a VATS. They saw an irresectable right iliac mass with high vascularization with superior cava and acygos veins involved. The histopathological report was poorly differentiated lung adenocarcinoma. The neuro-oncologist suggested not give any treatment for the paraneoplastic syndrome due to the low probability of symptoms improvement. So we refer the patient to our National Cancerology Institute to receive immunotherapy. On conclusion, the nervous system paraneoplastic syndrome might be present previously to a primary neoplasia specific symptoms. So it's very important to recognize it, and the early diagnosis gives the patient a better prognosis. Thank you.